All right, we're going to do a quick overview of obstructive versus restrictive lung pathologies. To understand that, we really have to understand lung volumes and different lung capacities. We're going to look at spirometry, specifically an emphasis on vital capacity, functional residual capacity, forced expiratory volume, and then take a look at compliance curves. So lung diseases, you can think of this equivalent to cardiomyopathies with the heart. So obstructive lung diseases have difficulty getting air out. So COPD encompasses emphysema and bronchitis. Then we have asthma and then bronchiectasis. For restrictive lung diseases, the difficulty is getting air in. So we can break these down into mechanical issues. So hypoventilation, whether that be a reduced tidal volume or reduced respiratory rate. So muscular issues, whether it be polio, myasthenia gravis, or Lambert-Eaton myasthenia syndrome, Guillain-Barré. And then we have structural issues like ankylosing spondylitis, scoliosis, obesity. Interstitial is probably a little bit more common, especially for your MBMEs. So this is largely going to result in fibrosis, which is going to cause a diffusion limitation. Remember that the distance of the membrane was one of the factors for the diffusion rate. Idiopathic pulmonary fibrosis is sort of a shrug of the shoulders, just fibrosis happens as you get older for whatever reason. Sarcoidosis, drug toxicity, largely chemotherapies, busulfan and bleomycin. And then we have hypersensitive pneumonitis. And then the pneumoconioses, which are really just when people inhale different types of dust. Asbestosis, barrielosis, silicosis, and then coal workers pneumoconiosis, which is really just the name of the overall category here. So like we said, obstructive, trouble getting air out. The alveoli, the lungs are going to swell, increased residual velocity, or increased residual volume, especially increased total lung capacity. COPD, which encompasses emphysema, bronchitis, again, bronchiectasis is going to be an issue. Asthma is going to be an issue. For restrictive lung disease, like we just said, difficulty getting air in, so you're going to have shrunken lungs, the opposite problem, difficulty contracting, so the lungs have a hard time filling and getting air out. Anything ending in osis, the osices like sarcoidosis and fibrosis are largely going to be restrictive in nature. So lung volumes, residual volume. So let's actually just start here. This is sort of our normal, this is where we live. We live in a tidal volume. So this is a normal inhalation, that's a normal exhalation, normal inhalation, normal exhalation. If I take in the biggest possible breath I can, we have our inspiratory reserve volume, IRV. If I take the biggest possible breath out, that's the expiratory reserve volume. Even after I blow off as much air as I possibly can, we still have some air left over in the lungs all the time, largely to prevent collapse. This is the residual volume. So this is everything we just saw. Inspiratory reserve volume, expiratory reserve volume, tidal volume is where we're going to normally operate, and then the residual volume. So the capacities are really just combinations of these. So the residual volume plus the ERV is the FRC. We talked about this. This is where PVR is a minimum, and where the elastic recoil of the lungs inwards is going to be offset by the thoracic pull of the lungs outwards, because the intrapleural pressure is -5, which is maintaining this nice equilibrium. It's also where the intraalveolar, intrapulmonary pressure is 0 in terms of its relative pressure to atmosphere. Inspiratory capacity is going to just be tidal volume plus IRV. Vital capacity is going to be these three things added together, IRV, TV, and ERV. And then, of course, total lung capacity, we can splice this up a couple different ways. So really just to hone in on that, total lung capacity is RV plus ERV plus TV plus IRV. But remember, FRC, which is really important for a bunch of different things, this is equal to the expiratory reserve volume plus the residual volume. If we combine these two, these 1 and 2 that we just saw, these formulas that we have, we can redefine the total lung capacity as the functional residual capacity, which is really just the ERV plus the RV, plus the tidal volume, plus the inspiratory reserve volume. Third, we have a vital capacity, can also be defined as the expiratory reserve volume plus the tidal volume plus the inspiratory reserve volume. So these three things together are going to be the vital capacity. So combining now formulas 1 and 3, total lung capacity can be defined as the residual volume plus the vital capacity. So spirometry, understanding these lung volumes and lung capacities, is going to be really helpful of distinguishing between obstructive and restrictive lung diseases. A flow volume loop, this is a common thing for a spirometry. So going in this particular direction is for exhalation, going in this particular direction is for inhalation, and the absolute value of the y-axis is going to talk about the flow, whether it's inhaling or exhaling. So if you're exhaling, exhale as hard as you can after taking the inspiratory reserve volume, the biggest breath you can. The peak flow is PEFR. FEV1 is I am blowing out for 1 whole second. That brings us to the forced expiratory volume 1. So it's probably going to come around here. If you're looking at something like this will be a tidal loop. So this is just maybe from like 3.5 liters to 3 liters to 3.5 liters to 3 liters. And then an inhalation is probably less significant, less focused. So again, like I said, this is after taking the largest possible breath you can. So, and at the same time, outputting the largest exhalation you can, which means that the difference between these two points on our curve is the forced vital capacity, also known as the vital capacity. So the total lung capacity here might be 6. This would be 0, no air, but of course we always have a little bit of air left in, so that's our residual volume. Another way of looking at this is just focusing on the rate of exhalation. So if we're looking at, this is starting here is the maximum. We've already taken the biggest possible breath we can, and now we're expiring, we're exhaling. So exhaling as much as you can up to 1 second, that is our FEV1. Notice we get most of the air out actually after a maximum exhale. So if you go for most of that right there, that was actually just really diminishing returns. Most of the air out gets out in the first second, and then the next 2, 3, 4, 5, 6 seconds or whatever, we're getting maybe 20% of the total air that we're going to get out. Keep in mind, you can't get all of the air out. So this maximum on this curve represents the forced vital capacity, because this is the maximum in and that's the maximum out. So this is my residual volume over here. Again, we saw the same thing over here. Total lung capacity down to functional vital capacity, and then the residual volume from here to whatever our zero value is. FEV1 going to here, not to be confused with the peak expiratory flow rate. So this is really the bread and butter of this. This is the main thing to emphasize, that obstructive lung diseases, this is really just going to shift our spirometry loop to the left. Emphysema, we're going to have increased lung capacity, more air in the lungs. You're going to see this on a chest X-ray with increased radio translucency, especially an increased residual volume. I really want to emphasize that. Your TLC goes up, your FRC is up, all that goes up, but the RV goes up the most, because you can get air in, but you can't get it out. And any air that you can't get out counts as the residual volume. This increases the most of all. You're going to have a really hard time getting out. That's sort of how we define obstructive lung diseases. So your FEV1 and your peak flow, your PEVR, are going to go down especially. Now looking at the restrictive, we have trouble getting air in. Getting air out is not as much of an issue. Maybe an issue, but not as much of an issue. We have smaller residual volume, smaller total lung capacity, and a smaller functional residual capacity. Now notice we also do have a lower forced expiratory volume and a lower peak flow, but it's not as pronounced as we have it with the restrictive. Importantly, the vital capacity is down significantly. We can consider a restrictive a shift to the right. Also notice that for the obstructive, we have this little characteristic dip that you should be able to just sort of identify just by eyeballing it. So for the flow volume loops, for obstructive versus restrictive, again, this is focusing on rate. Let's consider a normal situation. So maximum breath in, we're here. After 1 second, we're here. After blowing as much air as we can out, we're now at the forced vital capacity, also known as the vital capacity, and this is our residual volume, which is whatever's left over. So for a normal situation, I take a big breath in and I'm taking as much as air as I can get out. In 1 second, I get 3.5 liters out. I keep blowing for another 4 or 5 seconds. I get 5 liters out in all. So the FEV1 to vital capacity or forced vital capacity ratio is normally around like 70% and 80%. Anything below 70% is going to be diagnostic for obstructive lung disease, and we'll see why in a second. So obstructive lung disease, yeah, sure, maybe our forced vital capacity goes down a little bit. And this might seem counterintuitive because we just said that the total lung capacity goes up. You would think the FEC goes up as well. In some cases it might, but the idea is that the main thing is more air is in the lungs, but it's air that you can't get out. You lose, the emphysema destroys all of your elastin. You have very little ability to exhale this air. So your vital capacity increasing is really the reason for the total lung capacity increasing. So your FVC might go down. That's not as important as the idea that you can't get air out. So really significantly, the FEV1 is what goes down the most. So we saw normally it was 3.5, maybe now it's 1.5. And even though the FVC might have gone down in this scenario, it doesn't matter. The ratio is really what we're concerned with. Now it's 37.5%, well below our 70% diagnostic of bronchiectasis, asthma, COPD, emphysema or bronchitis, anything like that. Now, for a restrictive lung disease, notice that we kind of have the same problem. We might have trouble getting air out. I know that's not how we normally think of restrictive lung diseases, but nevertheless, that might be an issue. But more significant for restrictive lung diseases is we have a hard time getting air in. Less air in because they won't expand because of all of this fibrosis and whatnot, means that our total lung capacity or vital capacity, and yes, here our forced vital capacity are going to go down. So after the biggest possible breath, the most air you can get out is 2 liters. That is your vital capacity. That is very, 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 very low. So despite the fact that you have a low FEV1, the ratio actually kind of maintains itself at a 75%. They both go down, but again, the FEV1 might not go down, or might go down by an equal amount compared to the FVC. Compliance curves also change. So emphysema, we have no elastin. We can think of these as just big, stretchy, compliant things. So to get us to the total lung capacity, so the y-axis here is the lung volume, and the x-axis is the transpulmonary pressure, really just the amount of pressure needed to inflate the lungs. Looking at this first curve, the idea is that you do not need a lot of pressure to get to the maximum expansion with COPD. You need a normal amount for a non-pathological lungs, and very small amount if we're looking at fibrosis, any sort of interstitial lung, restrictive lung disease, pathology. Needed a ton of pressure to open up the lungs to this total lung capacity, despite the fact that the total lung capacity is a very small value.